Test.
I wanted to today share some that hopefully you'll hear more about soon. You can hear me all right?
Not good.
Yeah, I don't know if the mic is super loud.
I don't think it's on, Doc. Somebody. Yeah, it's on now.
Keep close. There we go. So hopefully you're going to hear more about this in the months to come as we are making another push in our profession to get more autonomy and access to patients who need our services. So I'm going to run through quite a few slides, but this is the first run. James. There we go. Okay. So first off, we're going to cover some issues today here on U.S. healthcare system, the current status of that system, and some critical issues that are there, and then understanding the physical therapy profession. So a lot of people don't understand fully what physical therapists do. They know that if there's injury, there's rehab, and they see physical therapists in that environment, but we do a whole lot more than that, and I hope to share some of that with you. And then some of the benefits that would occur if we were able to have unrestricted access to patients. Access issues. There's a little bit about health actions. I've been with health actions since 1998. I did move here to Dothan for about 6 years. Recognized there was a lot of opportunity to do the type of model of care that we provide in this area. So I went back home, and then we have been embarking on a growth experience here to try to get more exposure to communities across Alabama. So we
There you go.
I got it. So the current state of healthcare in the United States, we have rising costs. We have less than desired outcomes, like Jason was saying. There's increased demand for services. There's an aging population, and then there's a shortage of practitioners to meet the needs. Then there's access to quality of care and affordable care issues. So here is a graph that you'll see that shows since 1960 the change in cost of healthcare services. We've gone up dramatically, and they continue to go up. So this shows per person, the average person in the top 10 or 11 countries. The average cost per person is $5,800 a year, but United States it's $12,000. So that's a kind of a pretty significant difference right there in cost per person. Where that spending is occurring, You'll see these graphs here, particularly the one on the right. Prescription drug costs, and then outpatient setting environments versus inpatient. So the outpatient setting is seeing a larger expense, and then professional services. So that's the growth since 2014. So, of those, the problems that are out there that we're spending these medications and these services on, you'll see the change in this graph here from persons with musculoskeletal problems. The 1996 to 1998 is the red bar. And so when you go up through the age span, 45 and older, from 2012 to 2014, is that 3-year span has significantly where it was back in 96 to 98. So the highest rates are in back pain, joint pain, and chronic pain. And then this puts the greatest burden on the primary care practices, especially in the rural areas in Alabama. That's where they're taking the biggest hit. So bottom line, musculoskeletal conditions are not adequately managed at the primary care level. There's an access problem, contributing factors, they're just not enough. And for us, we're not able to participate like we should compared to other states to help meet this need. So that's kind of the big picture of this page. So musculoskeletal conditions are leading the pack. What conditions create the greatest amount of limitations in activity? They're the musculoskeletal problems. So the person's not able to engage in activities of normal daily living, they're not able to move, then that impacts all systems of the body. So the cardiopulmonary system, your immune system, all systems are impacted if you're not able to move. So keeping the musculoskeletal system capable to move as we get older is a critical issue, which is one that we specialize in. So you'll see that graph, that bar graph on the left. It's the ages of 65 and older, the yellow and the gray, that are really having the greatest trouble. So if that problem is impacting 65 and older, the projection over the next to 2060, you see the increase where we're at now, 6,000 or so. That's going to grow up dramatically. 56,000 to 74 to 82. So we're just going. The population is getting older, and so that demand is just going to get more and more in the future. So we've got to create a system that is more efficient and gets better results to manage our society. So. This shows us where we're at on outcomes for the amount of money. Remember, we spend $12,000 something per person in our country, healthcare, and you'll see that we rank last in the top 11 countries for this is affordability. But you'll also see overall performance. We're at the bottom, so we know something needs to change. There's been a lot of discussion about why are we so far below in our performance outcomes if we're spending the most money. So the healthcare system has been trying to fix this. In 2007, the Institute of Healthcare Improvement started this triple aim, and it was adopted widely in the United States. Our APTA profession adopts it. Everybody got on board and said we got to do something to improve our system. And so the triple aim is geared towards improving health outcomes and get the best use of resources and improve the patient experience in healthcare. What that did over time was led to practitioner burnout. And so then the attention turned to we've got to do something. So it went from a triple aim to a quadruple aim where they added the provider experience. So we wanted to improve the quality of life of the healthcare providers. And so that effort just hasn't made a significant amount of improvement yet. The burnout factor continues. There's still a shortage, and there's the access to care issue that's continuing to be a problem. So then recently, 2021, they come up with a quintuple, which adds equity and accessibility focus. So it's like we've got to understand the diversity that's out there, the patient populations, and factor that in on our decisions on how we're going to administer healthcare. So it's not all equal across racial and ethnic groups. There's lots of different things to be considered in it. Healthcare outcomes are looking at, well, you give me this outcome for this particular patient population, but how does it impact this other population? And they're trying to make smarter decisions on what needs to happen based on the individual person. So that's the efforts that are going on. It's to be determined right now for how that's going to impact. So access to care. How do we improve access to care then? In fact, we know that's a problem, particularly in outpatient settings, particularly for musculoskeletal problems. So then my solution as a physical therapist is we need more access to patients. So the term is unrestricted direct access to a physical therapist, and it's been proven to be effective. So that's a big part of the message is this is something that's already been established. You'll see the civil sector of healthcare functions differently than even in Europe and other countries, as well as particularly our military. The U.S. military model changed back in the 70s. Orthopedic surgeons were saying that they could not see all of the musculoskeletal problems that were coming in the door, and they wanted help. And so the physical therapist stepped in and became the first contact or the primary care provider for musculoskeletal in the military. And that continues today. So they're the first to make contact with a patient who's having musculoskeletal problems. And this study came out in 2022. This is a very recent study. This is a meta-analysis. So it looked at the call to action for direct access. It pointed out the fact that the U.S. military utilizes access, and it's calling on when can we have this in the civilian sector. And so the study went about looking at the status of direct access in the United States, and the results were basically the current literature. As they scanned the research that's out there, that's that meta-analysis, it's like the top of the research ladder. So a person's opinion is at the bottom, a case study, randomized controlled trials are here, meta-analysis is up here. This is a really solid study. And so it's determined that direct access for physical therapy is limited in the United States, and literature supports that we do that. So this is so this shows you in the United States the access to physical therapy that exists today. You'll see the red states: Alabama, Mississippi, and Missouri. I think Missouri is saying they have recently obtained access, but we're at the bottom here on this issue, and we have lots of rural areas, lots of shortage of practitioners. We have a critical need in Alabama, and so to see that we're still without access to practice, we have hope for the near future, though. That's why we're doing it. So I want to share with you a little bit about the physical therapist, the profession, and how we're qualified to help. Our doctorate level education now, so there's 4 years of undergraduate, and then there's 4 years of doctorate of physical therapy school, and then there's decision to be made of what specialty area to go into, and then there's residency options for these board certifications. Fellowships I've done, I have a board specialty and I've gone through a fellowship. They're growing rapidly in physical therapy, and they're basically specializations in particular areas. And so the curriculum of the physical therapist, we cover all the foundational sciences. We actually share instructors and labs and whatnot with medical school students. So it's in school, we're all kind of mingled together. When you get out into the profession, it becomes some boundaries and some lanes that you get into. So we cover all the foundational sciences, behavioral sciences, clinical reasoning. We similar to all professions, we study pharmacology, imaging, medical screening. So it's a lot. And then with clinical sciences, all systems of the body, the physical therapist has to understand, because all systems of the body are needed for movement. And so physical therapist is basically trained to be an expert in the movement system. So that system is its own entity. It's like your cardiovascular system. Your movement system needs to be managed over time, just like we manage other systems of the body if we're going to have a good result. So this shows you the different board certifications that we have, specializations. So physical therapists can choose to specialize in these different areas and there's different settings. So cardiovascular, pulmonary, electrophysiology, geriatrics, neurology, oncology, orthopedics. Orthopedics is the most common. Pediatrics, sports, women's health, and then there's still wound care management. So another big important thing is we have established practice guidelines that are research-based that help guide us based on conditions, what we should be doing. So we have a lot of good quality information. So we are the experts of the movement system. That's what we are. And that system is basically the collection of all systems together that interact to move the body. So that's the core of what we do. It's derived from clinical practice guidelines. We examine how the body's moving, and then we have an impairment-based diagnosis that we utilize to help guide our treatment. So a big part of it, though, is managing over the lifespan. So like Jason was talking about the dental model, part of our problem is we're seeing patients based on referral from other providers. And if we could do the model that we have a roadmap for, a plan for, we would see the person early in life before these things start to become a problem, before your joints start to wear out. We would help show you what's going on and how you could be doing simple things every day, like the brush your teeth things, to help prevent these joints from wearing out and things like that. So if the dentist would say, I tell this to patients also, if they only received patients from ones that were referred to them and they couldn't run their model, they would have the dentist, their office would be full of a lot of really bad teeth every day, lots of problems, and they would be frustrated, and they would say, if we could see patients directly like we want to and treat them over the lifespan, we could have a really better outcome for people for the dental health. Well, we're doing that for our teeth, but for the same model could be applied for the musculoskeletal system, that would be just effective. So that's where we want to be. So basically, the rationale for removing the barrier I'm talking about would be that we're highly educated. We're qualified to handle musculoskeletal conditions. We've proven to increase patient satisfaction. The sooner we can see the patient, reduce individual healthcare system costs. That's all been proven. I have a slide, some studies of that. 92% of patients who could benefit from what we do, we don't have access to. So they're not receiving that. So 92% are not getting what they need. At Health Actions, we have, it's over 300 a month that contact us, people that contact us with problems that won't help. And we lose so much opportunity when we have to, we can't see them directly. So there's another step that they have to go through, and that involves more expense to them. It takes more time. And so it's one of the things we have to deal with, and we've tried to implement systems that help us to be as successful as we can, but it's definitely impacts a lot of people. People that we've treated and we know we can help, and they just can't come in to see us. They could go to an athletic trainer, they could go to a massage therapist, but we can't see them. Here's the study. This is an important study. I think this one has some teeth to it, to kind of highlight our educational level with musculoskeletal. So this study by John Child, this was 2005. It showed the therapist's knowledge in musculoskeletal conditions. So it looked at all different types of medical professionals, and it gave them a test on the musculoskeletal system. And it looked at the scores. And so the orthopedic surgeon was on the left there, 94, and then the physical therapist with the orthopedic specialty was second, 81. So it goes down this. So physical therapists are right there with the orthopedic surgeons. You get into family medicine, gets into the middle. Get on down into internal medicine, it gets a little lower, and then of course psychology was the lowest, which makes sense to me. That's not their system. So it does show that we understand the musculoskeletal system. And so that was the point of that study. So the actual conclusion was that we can provide safe and effective care for musculoskeletal, and we can effectively provide it in a direct access setting. It reduces costs. The costs were less. And so it suggests that it has implications for the health care society. Here's another study. This compared the outcomes if a patient is having problems, musculoskeletal problems, and they went directly to the physical therapist versus they had to go to their primary care doctor first and then get a referral and then come to us. So it looked at that situation. And the conclusion was that direct access physical therapy is more cost effective, fewer visits than the physician first access in the United States. And we have better outcomes because the sooner we can treat these problems, the better. And as we get to know our patients over time, we can kind of know the tendencies for each individual. And it makes it so much easier to get them to handle the situation when you know the patient. And so if everybody has their physical therapist, just like you have your primary care doctor and whatnot, then that's going to be the ideal way to help keep everybody moving in society and have a better quality of life as we get older. A little bit about health actions here. So we've been on since the therapist on since 1981. We really stress over and over our values. We look to make sure we're hiring people that have the same values. We want to take care of people. We want to be servant leaders, and we're passionate about our profession, and we're continual learners. That's kind of the essence of who we are at Health Actions. We organize into teams, and these teams are driven to be efficient at taking care of patients and then getting outcomes. We're also expanding to really impact society. We need in more locations. I've got a slide with locations here, but we're adding more to what we have. We're in 10 locations now. We start in Orange Beach next month. So we're in Jackson, Alabama. A lot of them are rural areas, which is why we're interested in the rural health access as well. But Jackson, Alabama, Monroeville, Thomasville, Atmore, Gaffney, Orange Beach, that's our southwest side. And then we have here in Dothan, we have 2 facilities, and we have Troy and Enterprise. And so our goal, though, is we need to have a certain footprint and geographically kind of strategic locations so we can continue to be successful. So we're planning to work across central Alabama. We have plans for Tuscaloosa and across the Florida Panhandle, so we can kind of connect And we don't want clinics to be too separated from each other. So we're trying to run a goal where we have a large enough impact in Alabama. So we make choices as a profession, so we're not choosing to be independent. We want to be a team and a group. We align with our profession very closely. We're very involved. We want to help the healthcare system. That's a huge part of what we are and what we want to do. We want to accept insurances. We work with Medicaid. We work with underinsured, uninsured. Really, it's real common in the rural areas. We have to be very, very creative in our systems. UAB had us up talking about the sliding scale system that we use at a conference. It's just a way to adjust how much the patient has to pay out of pocket based on their financial situation. And so we try to balance the amount of care they need versus what we have to have a margin to have a mission. We have to exist. So that's some of the challenges that we have to battle as a private company. But we feel like it's important to be able to administer the service and be productive at the same time, be profitable. So we can serve society better if we can do that. So this is a diagram we've used since the 80s. It's a paradigm on the right there that just highlights the patient, basically the movement system and how all systems interact. And so we train on this. We train the movement system, like I'm talking about, to our therapists. So they come to us out of school. They come, they're interested in learning what we're teaching. And they often say that this is what they wanted to know. When we get to them, we start teaching, they love it. It's really helped us to grow because we can recruit therapists. We actually have a roadmap for a patient that takes them through phases of care, and each phase has its own set of problems that we encounter. So we learn how to address each phase, and we have a long-term goal of having no issues in any phase of care. But it's basically a roadmap where we could take somebody over time to a much better functional state. We, like I said, there's a lot of education we provide in our physical therapy practice, which is pretty unique to us or to the profession. No other companies are really doing this. You don't see director of clinical education in a lot of companies. It's because we value the learning experience, and we feel like it's critical. The years of experience that we have packaged it into curriculum, and we teach it to therapists. There's a lot of our strategy too to help get therapists to come to these rural areas. It's hard to get them to go to Thomasville. We're at more places. We really have a hard time getting physical therapists to choose to come to these rural areas. But we do offer the training in movement science, how to examine the body. We teach them how to recognize syndromes and this impairment diagnosis that's important. And then the treatment programs we have are pretty unique and all very effective, get results quickly, and there's no risk. There's very low risk. So the side effects on our end are really low. So another part was we do a lot with universities. We're working now with UAB. They have high interest in rural health, and the physical therapy department there has created this advanced curriculum for physical therapists to learn how to manage patients in rural areas. And so we connect to them for this fellowship program so that the therapist gets support through their education, and then they come work with us in the rural area where they're trained. So it makes more sense because they're specially trained to handle the conditions in a rural situation, and that's what we do. Just to show you here at the end, we part of it was doing pretty well. It was on a roll. Almost there. There we go. You got it. Let me tell you first about, so when we're teaching, the whole point of why we're trying to have the system that we do for being able to manage a patient is the term flip the pyramid. So we're growing and developing. Our goal is we say flip the pyramid. So the traditional system on the left is majority of expenses, surgery, injections, and medications. Physical therapy is a small amount. We want to switch that to where we're a larger part, but in the grand scheme of the healthcare expense, it's going to be smaller. We have a larger role. This is interesting. So medications, injections, imaging, and surgery. So these are musculoskeletal situations. 72% of the healthcare expense for musculoskeletal is on that. For every $1,000 spent for musculoskeletal, 72% of that is going to those things. So conservative treatment for musculoskeletal is 10%. So $100 of every 1,000 is conservative care, but that bundles a lot of different specialties. Our piece of that for physical therapy is 2%. So $26 of the 1,000 for musculoskeletal is spent with physical therapy. So that's how small of an impact we're able to make at this point in time. 90-something% of people that benefit or need our services and can't receive it, and our outcomes are better if we can access people quickly. So thought that was important. So that's kind of the ideal scene here would be our plan. We have this pyramid flipped, and it's because our plans of care are more expensive. Or less expensive compared to surgery and injection. Especially the medication. Medication costs are kind of hard to factor because of the side effect situation, and then medications on top of medications because for side effects, it just keeps going and going and going. So for the money you spend in physical therapy, the outcomes are really good, and our goal is to keep patients healthier. We do it naturally without the side effects, like I was saying, and so it's just trying to help make us more of a factor in the system. Is what we're trying to do, and unrestricted direct access to a physical therapist is critical to making this happen. So that's my. Any questions?
I'm assuming 3 states, you're talking about, said Missouri, there's no direct access. And so, but I saw 2 different colors on your chart there. So is there a level of access in some of these states versus others?
So there's levels where some have restrictions where a certain condition you can see certain number, you can see them once or twice, and you have to refer them. So there's restrictions on the access. And so there are some restrictions that we, can be reasonable, like it's so many number of visits, so many months if we're treating and there's not a change, then we would refer. But that's really not how we practice. We work interchangeably with the medical profession. We see patients come in that we recognize this is a medical problem. This doesn't look like musculoskeletal. You need to go see. And we make a lot of referrals into the healthcare system, things that we catch, things that physicians miss that come to us, and we look at it and go, I think you missed something. I think we need to take a second look at this situation. So so the other states, basically, they have restrictions. We can examine, but we really can't do anything. So it's kind of it's just enough to be frustrating, actually. Yes, sir.
I noticed many of these health actions that were on the board that you mentioned, are they preventative measures? Are you the end result of people who were not given opportunities for certain things like proper exercise, proper diets, those kind of things that should have been done?
Right.
You mentioned the small rural communities that they don't have access to good health practices. I understand brushing your teeth,
Right.
But I'm talking about the muscular skeletal side of it.
Yeah.
We assumed that farmers of old didn't have any health problems because they were physically active.
That's right.
But
well, that's the deal. And
so you're the end result of people who didn't have those opportunities.
Right.
Is that right? I see. Okay.
We recognize society has changed, and it's critical. We recognize this imbalance is just like with the dental profession. They have a cavity issue. We have cavities, right? And so the movement system itself has a problem with muscles that are out of balance. And that imbalance is coming from the sitting situation is one of the leading things. So sitting creates a problem between our muscle systems. And so the more the system is out of balance, the more it puts stress on joints when you do move. And that leads to the arthritis and things like that. So we have a way to recognize those risk factors so we can find the risk factors. We have a movement system test where we can find risk factors that show you that the system is not optimal. It is using the wrong muscles when you're moving. You can move and do, but it's with the wrong muscles doing it. We have to show you that though, so we have certain tests we put you through so you actually see that you can't do it. And then we show you how to start to be able to do it. And that's the sooner we can do that, you understand our language and things that we're showing you that the sooner that happens, the better. So, yes, sir.
Would it ever be feasible to have an in-house position that you could go in and be evaluated there, and then they could be able to put you in a program?
There are, that's great. If we had physicians that could really do that, they're so busy in their world. There's so many things that are important to us. A lot of times it's not the same for them. So everybody kind of has their specialty and their lanes. And so I've worked that way. It works great. When I shared space with an urgent care center, it's really great. They'll come to us and say, could you look at the shoulder? I've got somebody here. What do I think I need to do? And we could do our check on them and see, the rotator cuff looks okay. Let's don't go for an MRI. Let's do the injection. If they're diabetic, they don't need the cortisone, stuff like that. So it's a great working relationship like that. So the idea would be like a medical mall or musculoskeletal type mall where you got urgent care. And we're actually working on something similar to that in Daphne. Orthopedic surgeon, us, and urgent care. So when you're having musculoskeletal problems, you can get the whole team. And we're just looking for another. It's another opportunity for the patient. It's a choice. It's not a mandate. It's like adding another lane to a road that's getting too congested. It's a choice. You can get on that lane or not. So it's just another choice to come see us if you're having trouble. So we have a lot of patients though in past experience that want to come see us. We see it all the time. They're coming to us saying, "Can you see me again?" And I'm like, "Well, yeah, but I need to get a referral." And a lot of times that's the problem. So
Who controls that?
Our Practice Act will not allow us to just see them directly. So we have to have a referral in Alabama, which is, like I said, we're one of the last states that has that situation. So a lot of.
Is that the legislature?
Right, yes, sir. So we're working on that. That Jason is the chair of the Government Action Committee. We actually. Oh, yeah. Okay.
Has there been what's the communication between master orthopedics and or the insurance payer at this point? And has there been any communication between those three to try to find some kind of common ground to be able to move forward? I know that's been a problem in the past.
It has, and I believe at this point, we are on the right track here. So even with the insurance companies coming on board, saying that they will pay Blue Cross and whatnot, if we have direct access, that they would pay, because they're happy with the way things are going with patients who see us. And there's positive efforts. Jason may speak to that here.
So to answer your question directly, the conversations that we've had with Blue Cross Blue Shield of Alabama, for example, have been very positive. Basically what they've said is that they would support that and pay for it as long as it passed the legislature. So that's the message we've got from them. That's what they have in other states. They're not unaccustomed to it, so they're not fearful of it at all. In fact, a lot of insurance carriers now require physicians to send or make a conservative care referral before they'll approve surgery. So they've learned that saves them a lot of money.
Has there been any small movement in orthopedics would agree to where there could be some kind of work together? Or I know at one time it's a big step. Is there some way you can step back and make small steps at a time?
Yes, sir. So we, you know, and I know we haven't had a chance to talk, recently, but, we have spoken to them, and we've considered we actually had an agreement 2 years ago to move forward, and then COVID happened. Imagine that. So that kind of killed everything, and there were other priorities in the legislature, which is very understandable. So in 2023, we're going to be approaching the state legislature again, and we'll be in direct contact with them. The starting point would be where we were 2 years ago, and then we'll have dialogue from that point forward. But we did basically have an agreement with them 2 years ago. Other questions?
Thank you, Dr. Burnett, for being with us today. Very, very good presentation, and thank you, Jason, for being our speaker today. I want to say thanks to those that helped out with today's program, Bo Bagger, Terry Duffy, Stephanie Walker, and Sheila Azar. Also wanted to thank the guests that came today, Lee, Logan, and Chris. Great to see you all. Hope to see you back again soon. With that, also next week, our program will be Nancy Brooks with the Joy FM. If you will, please stand with me to recite the four-way test. Other things we think, say, or do.
Is true, is fair to all concerned, would it build goodwill and better friendship, will it be beneficial to all?
Have a great week.
Just